I'm going to try to give you some practical handles on how to treat Hodgkin's disease and show you that we've made some progress just by use of the PET scan itself. Stage change after PET. There is no doubt that some patients with Hodgkin's lymphoma can have changes in stage by virtue of the PET. We're talking about a patient presenting in your clinic. There are some who will be upstage and some who will be downstage. Most of the time they get downstage, but there's been really not a whole lot of change in Hodgkin's disease in terms of what you're going to do to the patient. For many years prior to PET scans, some of us were convinced that radiation doesn't work very well and we would just simply give them chemotherapy and it was a no-brainer. But most of us would give 6 cycles of ABVD regardless of whether they had 2A or 2B disease. Change in stage usually occurs more with non-Hodgkin's lymphoma, and I just would like to point out that there was an excellent abstract with regard to that by Dr. Go here at the Bridging the Gap meeting today. You can take a look at his poster. And indeed, he recognized that by virtue of the fact that PET scans were authorized by Medicare, that in fact it enhanced survival because you were able to upstage patients and give them more effective treatment. So what is the charge for us? The charge is that 85% of Hodgkin's patients will be cured. So the whole charge for us now is how can we make these treatments less toxic for the majority who will be cured and make treatment for the less fortunate more effective, avoiding prolonged therapy that simply isn't working. So effectively, what can PET scans do in regard to that? Well, it would be nice that we could really identify a subset of patients who turn negative, and maybe we can give them less therapy. And early on, if we can see that the PET scan is positive and absolutely confirm it with pathology, that we can take these patients off what is ineffective therapy for 6 months. Many of us, before the advent of PET scans, would just simply give the patient 6 months of chemotherapy, do a scan afterward, and then we would find out that the patient only had a partial response. So PET scans can be helpful both in determining those patients who are going to do very well and those patients who are not going to do very well. Now, the first benefit from PET scans was almost everyone here, I'm sure, accepts the fact that PET scans should be done after the completion of 6 cycles or whatever therapy you choose. But one of the nice things about PET scans is that you very often will encounter patients who have residual masses, and you don't know whether this is active disease or inactive disease. And this report by Dr. Salvage many years ago, 7 years ago at least, indicated that if you had a mass or a bulky disease and you had residual disease and you did a PET scan, it was negative, that these patients did almost as well as those who had no residual mass. So I think all of us here will accept the fact that PET scans at the end of therapy is really the common approach to treatment these days. But one of the nice things about PETs is that if you get a negative PET with residual masses, you may not want to irradiate that patient and simply watch them. But what about the value of PET scans amidst therapy? Well, one of the first studies was done by a fellow by the name of Morton Coleman, who looked at limited stage 1 and 2 patients, and he looked at PET scans after 2 or 3 cycles of chemotherapy. And what he found out is that if you had a negative PET scan, only 1 in 50 patients relapsed, whereas only 2 of 70 with positive PETs relapsed. Now you'll say, well, that's 5 false negative PET scans, but in point of fact is most of these patients receive radiotherapy, and we know that radiotherapy may work when chemotherapy is not being effective, and in fact the patient may be resistant. So you can overcome chemotherapy resistance with radiation, provided there's relatively limited disease. Now, some people contend you can get just as much information from the International Prognostic score, which was advanced by the people in Germany, particularly by Volker Diel. In point of fact is he has 7 different characteristics. You don't need to memorize them. You can find it from the New England Journal article. And he had a score of 0 to 7, and he in fact said that if you had a score of 0 or 1 or 2, you did very, very well. If you had a score of 3 or above, you didn't do so well. And he really separated these patients into what he called good risk and less good risk. Now, the people in Canada said that in this day of newer therapy, that frankly 3 and 4s don't really matter very much, but those who had a IPS score of 5 or above, these patients did less well, and only 2/3 of the patients seemed ultimately to benefit from the therapy. So this is the IPS, and I have people who still doubt the efficacy of PET scans who say to me, I could get the same information from the IPS, which of course I don't believe. So we have two questions. How do PET scans fare compared to the IPS? And are interim PET scans of value, or should PET scans be done only at the completion of treatment? Well, this is an early response assessment using PET in patients with Hodgkin's disease by the Italian investigator, Dr. Gallimini, and he showed that regardless of your IPS, if you had a negative PET scan, you did very, very well, and if you had a positive PET scan, you didn't do very well at all. And this looks almost like an all or none phenomenon. And indeed, Dr. Michael also said the same thing. He said over here, if you will look, he said that if you had a negative PET scan, you had an 8% relapse rate. And if you had a positive PET scan, everybody relapsed. Well, some of us may take exception with that, but nevertheless, the data are rather impressive. And yet a third group of people, and we at Cornell showed the same thing, that if you had a negative interim PET scan, let me go back one, if you had a negative interim PET scan, again, your chances of being cured looked pretty good. If you had a positive PET scan, the outlook was not very good, and it looks like an all or none phenomenon. However, if you look at this very busy slide, there were some people who had exception to that. The French over there said, hey, wait a minute, we're getting a fair number of patients who had a positive PET scan who were doing pretty well at the end, even though they had an interim scan at cycle 2. If you look up here, though, there's no question that regardless, if you have a negative PET scan, that you're going to do very, very well. And if you look up here by Dr. McHale again, if you have a positive PET scan, that's strongly positive PET scan, you don't do very well. But if you have a good response, but not a total response, you still may do okay. So now we're beginning to get some information here that if you have a negative PET scan, you're going to do fine. If you have a strongly positive PET scan, that is, if you go from an SUV score of 8 to 7, you're not going to do very well. However, if you go from a score of 8 to maybe 3.5, perhaps you will do all right. So that may explain some of the discrepancy, but there are other reasons as well. And they include variability amongst the readers. What do you call positive and what do you call negative, particularly if you're using the eyeball? Most of us now use a semi-quantitative measurement using the SUV. There's been a lack of standardization, injection time, different machinery, and so forth. And again, as I mentioned before, what does a major but incomplete drop in the SUV signify? So today, we have developed what is called the Deauville criterion. And most of us accept that scores 1, 2, and 3 represent negativity, and scores 4 and 5 represent positivity. And with that in mind, Dr. Hutchins, who did one of the original studies, Dr. Costagoglu, who worked closely with me and myself, decided to take an international study on to find out whether 1 cycle does as well as 2 cycles. So we're talking about looking at a patient who's been treated with, let's say, ABVD or Biacop. After 1 month, we're going to do a PET scan on them. That's 2 cycles of ABVD versus 4 cycles or 4 treatments with ABVD. And we had 4 countries participating: Denmark, the United States, Italy, and Poland. And we had a fairly broad spectrum of stages from 1 to 4, and half of the patients had B symptoms, and a third of them had bulky disease. And the results we got is that we had, if you did a PET scan after 1 cycle and you were negative, there was a 92% chance that you would not relapse. And this is with data that had been generated with a minimum follow-up of 3 years. Now, if you had a negative PET scan after cycle 2, there was a 7% greater chance that you would relapse. But regardless of whether you did 1 or 2, less than 10% of patients would relapse if you have a negative PET. So I am contending that at the end of 1 month of therapy, I can predict to you who's going to be cured. On the other hand, if you had a positive SCET scan after 1 cycle, there was about a 40% chance that you would do okay. But if you did a PET scan after the 2nd cycle, there was a 15% chance that you would do okay. So what we're saying, though, is those rapid responders are going to do very, very, very well. So I'd like to talk to you about the RAPID trial that was done in England and was reported at ASH in 2012. And what these people simply did is they gave 3 cycles of ABVD. And this is, again, for limited stage disease. And if you were in complete remission by PET scan criteria, this is after those 3 cycles, they then would give you either radiation or they would give you no treatment at all. So forget the PET positive patients, just that they randomized the PET negatives, that's a PET scan after 3 cycles, not 6 cycles, between involved field radiation and no further therapy. And what they found out is that there were more progressions on the negative PETs that had no radiation versus those that had radiation, that is 20 versus 9. But overall, the progression-free survival and the overall survival were virtually identical, and the reason for it is that there was a lot of complications when you gave radiation after the 3 cycles. So important a fact is there were 75% of the patients in this particular large study who were negative after central review after 3 cycles, and it turns out that the progression-free survival was only different by about 3%. And that was within the maximum allowable difference of 7%, which they had calculated. So what we can say is that if you have a negative PET scan with limited disease after 3 cycles of ABVD, you have an excellent prognosis and you really don't need radiation. So this is a change in therapy by doing interim PET scans. What we're saying is you can cut in half the chemotherapy that you want to give for patients with stage 1 and stage 2 disease, and you don't need to give any radiation. Now, in point of fact, this is similar to data that was reported from Argentina for all stages of disease. And what I contend is that slight difference in false negativity that you saw with the patients who did not get radiation, had they done the PET scan at cycle 2, or better yet at cycle 1, well, they would have had no problem at all. Nevertheless, response-adaptive therapy based on quality-controlled assured PET imaging may become the future standard of care in early-stage Hodgkin's lymphoma. Now, I want to briefly talk about BIACOP versus ABVD. Everybody in Europe uses BIACOP, and everybody in the United States does ABVD. And the issue has been, which one is really truly better? So the EORTC looked at advanced stage Hodgkin's disease. That was high-risk patients with an IPS equal or greater than 3, and these were stage 3 and stage 4 patients. And so what they did is they randomized between ABVD and BIACOP, the usual standard way of being treated, with no radiation. What they found out is that progression-free survival was clearly superior to BIACOP, which is certainly more intensive therapy and more toxic. However, there was a lot of discontinuation of treatment due to toxicity, primarily of BIACOP, such that the event-free survival is really pretty much the same, and the overall survival is not much different either. Now, Dr. Vocadil and I are very good friends, and we fight all the time. And I keep telling him, well, why don't you do a PET scan after 1 cycle with ABVD? And if it doesn't look like you're doing very well, go ahead and put the patient on BIACOP. My only worry, though, is that if you really have a poor response on PET scan, that means you have inherent chemotherapy resistance, and you're just simply not going to do very well. And that perhaps maybe we should think of some novel therapy, including brentuximab vedotin. What I'm saying is a positive, strongly positive PET scan after 1 cycle of therapy, or certainly after 2 cycles of therapy, if you have not had much drop in your SUV score and you document that you've got persistent disease, you're not going to do very well, regardless of whether you switch to BIACOP or even to an autologous stem cell transplant. Nevertheless, the event-free survival between ABVD and BIACOP is really pretty much the same because of the early discontinuations. And while the progression-free survival with BIACOP was better, it's still not good enough to improve overall survival. So that when you're trying to decide whether you want to treat a patient or not, there's a lot of considerations. There's cost, morbidity, fertility, and a whole host of other things before you decide whether to give BIACOP and ABVD. I can tell you personally, I don't use BIACOP, I use ABVD. Now, these data that the French showed is pretty much similar to about every other study that's been done. So as I say to you, not only can we select out, I think, patients for less therapy with disseminated disease, with limited disease, but also I think we can pick them out with disseminated disease as well. And we are routinely now doing PET scans after 1 cycle. And just to show you that interim PET scans have really made the mark, this is just a small smattering of all the multiple studies using interim PET scans to determine how you're going to treat your patient with Hodgkin's disease. So in conclusion, I can say early PET scans can predict at a high level those patients destined to be cured. Overall, well less than 10% of patients deemed negative will relapse. And positive PET scans are more problematic, with many positive PET scans proving to be false in those instances where a major drop, that's 2/3 of the PET scan score, but not complete drop in PET uptake occurs. Nevertheless, as I said before, a small drop in the SUV score portends a poor prognosis. And the question really comes up is, can these patients be rescued with any manner or techniques, because these patients have inherent chemotherapy resistance. Now, having advocated for doing an interim PET scan, the one thing I'm not advocating is doing sequential follow-up PET scans on patients who have negative PETs. As I said to you, the chances of you relapsing on an early PET, after a negative early PET scan, is less than 10%. When you look at the data, those patients who get followed up with serial PET scans, only 1/3 are picked up by the PET scan. 1/3 is picked up by the patient, the recurrence, and 1/3 of the recurrence is picked up by the doctor. So that leaves you with roughly 3% or less chance that you're going to pick up disease. And there's not a whit of data to show that the early detection of disease is going to inherently give you a better prognosis. So if you find out that the disease has recurred 2 months later or 5 months later, I don't know that it's going to make a lot of difference. An important fact is we're subjecting people to a lot of radiation and expense that they just don't need. So I advocate that if you have a negative PET scan, you don't need to do follow-up PET scans in the future, particularly if it's negative after one cycle. And the bottom line is interim PET scans are indispensable to the treatment of Hodgkin's lymphoma, and I thank you for your attention.